I'll be chairing the meeting this afternoon as James Bullion has sent his apologies. As per usual, this part is being recorded and will be available on the YouTube channel afterwards. Conscious there's quite a bit of paper in today's meeting because last month's ordinary meeting was cancelled. There was a meeting in a smaller group, which you'll find an update on in the minutes as we go through them. I didn't have any specific chair's action for this afternoon. Apologies today have been received. James Bullion, as mentioned, Mark Burgess, Rosemary Moore, Fiona Thiedem, James Reeder, and Sadie Parker has just stepped out but should be back before long. Let me check, Sarah, any further apologies that we've received?
Not to my knowledge.
Okay. Good. Then declarations of interest. You've seen them in the pack. Is in view of today's part 1 agenda. Is there anyone who needs to highlight an interest? I'll take it as a no. Then we move to page 5, the minutes of the previous meeting. It's both the ordinary August one first. So is there anybody who has a comment as to accuracy of those minutes? Okay, and then you can read what was discussed in the mini September meeting. So any comments as to accuracy on those? No, then thanks very much, Sarah, for preparing these. Moving swiftly on to page 23 of the pack. That's the forward planner. So that's there for your information. I suggest we don't go through it in detail. And the next page takes us to the risk register. When I caught up with Sadie this morning, she was planning not to say too much on it. You will have seen there's an increased risk score for GP resilience for the reasons outlined. But let me check with anybody on the call. Is there anything people want to query or highlight or comment on in the risk register when they reviewed it? No. Then I move to, oh, sorry, Mel.
Sorry, I was a bit slow putting my hand up there.
Yep.
We just wanted to, we sent in comments, Naomi sent them through last week on Thursday the 10th regarding PC1 and the resilience fund just in part 1. So PC1 regarding workforce.
Okay.
There's a significant issue with non-clinical general practice workforce as well as clinical workforce.
Yeah. Yeah. I remember seeing the email. Thank you, Mel. Hilary.
I didn't know to mention it now, I'll mention it later. But I noticed in his report he mentions about the abuse that primary care staff are facing, which is a real significant issue across practices, and you'll have read things in the EDP, and if you talk to other practices, the levels are, I don't remember it ever being so bad, quite honestly. And that's having an impact, obviously, on staffing and all of those other things that link to GP resilience. So I was kind of thinking about it, and I was also talking to Alex from Healthwatch about some of it, because we've had some issues in our practice with people being really, you know, I mean, verging on, you should call the police, actually. People stopping people outside the building when they're on their way home and being abusive because they've turned up after the building's shut to get their prescription, and therefore, so things that are just not reasonable. And I do think we need to probably just look at what we're doing in order to support practices, and that kind of, as I say, links to resilience, but also it made me start to think about what our wider strategy is for primary care. And if we look at our work plan and look at the things that we discuss, some of it is quite contractual, and that's fine. But actually, if somebody said to me, can you articulate in 3 sentences what the strategy for primary care is going forward, I think I would struggle a bit. I'd reference other strategies, but I don't know that. So I wondered if that was something that we needed to think about, or where that would sit. Does that sit here, or does it sit, do we need to do something outside this meeting to pull all these different strands together that we worry about?
Yeah, good point. I don't know the answer, but it's important it's being picked up. And as Sadie, Mark is here at the moment, I'll make sure it's flagged. It might also not just be something for this committee, but also the Patients and Communities Committee, because I think it's important they have sight of that as well. But thanks for raising it. Shep, is there something you want to comment on?
It was just to notice that Chris Turner, his hand is up, and I know we've been working on some of these discussions around access, and there's a lot going on, but I think it's about how do we pull together everything that is going on and provide the information that is required in the system. I recently attended a practice meeting with practice managers, and one of the asks is exactly what you have pointed out, Hilary. Help us educate the public about the pressures that we are facing and how hard we are working to try and address their needs. And specific comment was the public to identify their needs rather than their wants. That was the message that I was given from that meeting. So there's a lot that we are doing, but it's not enough yet. I think at this point I will probably bring in Chris, because I know that we've had some discussions around some of this work.
Yeah, I'd agree with that, Shepherd. So there is some work we're taking forward just around the access piece with Health Watch, and I caught up with Fiona around pulling some of those strands together a couple of weeks ago. There's just a very brief point I wanted to raise. It kind of links to the resilience. It was slightly different to what Shepherd had mentioned. Just around on the 2nd of November, we've got our first primary care multi-professional forum, which is for the nurses and allied health professionals in primary care, which is being chaired by Tricia Dorsey, our Director of Nursing. So it's kind of a kick-off meeting, and hopefully that's something that will evolve and take forward, and I'll give an update at a future primary care committee probably next month to give an update on how that went. That's okay.
Thanks. Any other comments on the risk register? Good. Hilary briefly referenced to it. So the next agenda item is an update from Mark Burgess, who sent us apologies for this meeting. And Hilary, you touched upon the third part of the note already, and I'll make sure we'll give it proper follow-up in this committee. I'll liaise with Sadie on it. I'll take the paper as read, but happy to invite comments people may have or questions on this note. No. Thank you. Then I move on to page 41, the GP patients survey. I think Kate will join us for that. Sarah?
You will, I'll just dial her in.
Yeah. Good afternoon, Kate. How are you?
Hi, well, thank you.
We're at agenda item 8, and I think we can afford a bit more time to make sure we hear feedback and input from everyone. In the meeting, as usual, you can assume the paper is people have had a chance to read it, but I'm sure you want to pick out a few highlights from it. So over to you.
Great, thank you. Hi, everyone. For those who don't know me, my name is Kate Lewis, Head of Primary Care Strategic Planning, and I've been asked to present the paper on the GP patient survey for 22-22. So yeah, I've taken the paper as read, but I want to just provide an overview of the findings from the survey and compare our findings, our system view, to the national average. And I think it's really interesting, the findings that have come out through the survey in the context of demand for GP services and the pressures that our general practice is facing. And for the first time, the survey allows us to draw comparisons between PCN areas, which is a really useful tool for us. So just a brief overview of the survey. It's run by Ipsos Mori. It's been running a few years now. And the GP patient survey, it covers feedback primarily on access, feedback on making an appointment, ease of making an appointment and experience of making an appointment, and quality received, the quality of the care experience. The response rate was 39%, so lower than previous years, but in line with the national average. The really key salient points to take away from the survey is system-wide, our practices were above the national average across all categories within the survey, although it follows the national trend. So we've performed lower on most categories than we have done in previous years. And I think the significant finding from the survey is that 3/4 of respondents on the survey would rate their overall experience as good. However, as I've just said, this figure is a decrease on the 2021 survey, but that's in line with the national average. Sorry, not national average, that's in line with the national trends. So what I wanted to say is, if we start to triangulate some of the findings from the survey, and then I'll go through the recommendations that are outlined in the paper. The survey also comes out at a time when general practice is facing immense pressure, and it's in the context of increased patients' expectations post-pandemic. And that's all relevant. It's not included in the paper, but I just wanted to highlight because this is something that we're being asked for quite regularly in terms of providing feedback to media requests and feedback to MPs, is that 81% of our primary care appointments are delivered within 2 weeks in Norfolk and Waveney. And I think that's a relevant statistic to have when we're considering the findings of the survey. And 40% of all activity takes place on the same day across general practice. And no doubt you would have seen, if not already discussed, the EDP article, which recently talks about the abuse that some of our general practice staff have been facing. And the EDP article references humble yard practice. And you know, that one practice alone quotes experiencing 700 calls in one day across all their sites. So we're talking an immense amount of activity on general practice. You know, and across Norfolk and Waveney, on average, you know, we deliver about 25,000 patient appointments per day. So a significant amount. So I think the key takeaway from the paper, and for members of the committee to consider, is, you know, the next steps and what do we do with this intelligence and findings. And for me, it's about how we try and triangulate patient feedback from the survey and all the detail in there, comparing practices, comparing PCN areas with the statistics that we have that I just kind of shared with you, to start to feed into the resilience picture of primary care and the picture of primary care resilience in the system. So how can we contribute to understanding that overall picture of primary care system pressures? In the paper, very clearly that the findings from this report is extremely helpful in shaping our new enhanced access service provision, and I believe there'll be a report coming to a future PCCC meeting on that. But I just wanted to highlight that, you know, these findings are really key to feeding into our programme of work around demand and capacity planning. So it's a real challenge comparing activity across our practices, and that's a piece of work that we're undertaking, working with NHS colleagues, working with colleagues across the BI and digital teams to start to try to really quantify the impact and pressure on primary care. Any questions, please?
Thanks, Kate. And just for your and also Sadie's awareness, Hilary did raise the point on significant being abuse being directed at staff in practices, and I can touch base offline, Sadie, on trying to frame what sort of the larger action plan to address that. But I think it resonates very much. Let me check if there are questions. I'd be interested, as we have two representatives from HealthWatch on the call. Maybe Andrew, I can start with you on your takeaways from seeing this survey and having seen them over a number of years.
I think Andrew may have frozen there.
Sorry. Sue, I think you're online.
Hello. Yes. No, it was very interesting just to hear that, actually, Katie. We actually did back in July some feedback ourselves. I don't know whether you caught sight of that, but I'd be interested to know, was there any questions around face-to-face appointments at all as to how people felt about that? Because that was one of the things that was kind of raised for us, that people felt very frustrated about the concern about not being able to get face-to-face appointments.
Yeah, I was just scrolling through my paper to see if I could pull the figure out for you, Sue. I don't know off the top of my head, but I'm sure there is a question in there about face-to-face. There's definitely about ease of access, and the questions sort of describe the various modes by which patients can try and book appointments. I need to go back to the detail, Sue, and get back to you if that's okay.
Thank you. That's great. I can look as well, I guess, myself, can't I? But thank you for that.
Lady, before I let Andrew, maybe you want to respond.
Yeah, I with like Kate, I have to say I don't know whether there's a specific question on face-to-face, but I think what is very interesting is that there's a kind of general perception, and then there's the actual picture on the ground. And notwithstanding the fact that there is variation between practices and there are different levels of satisfaction among our practices, patient populations, but the national average is, I think, around 62%, the last set of figures of patients that are being seen face to face, whereas in Norfolk and Waveney the average is around 72% of patients. 74, thank you, Kate. It's obviously gone up since the last lot of data I looked at. So I think there is definitely a bit of a mismatch between what's actually happening and a lot of the media coverage that's we see around all of this. And indeed, I was in a practice in Norwich to meet with the partners the other week, and they had 100% face-to-face figures up on their board, just informing their patients that they'd seen every single patient face-to-face in the previous month. So there is definitely variation there, but I think overall it actually looks quite good in Norfolk and Waveney, and certainly as part of our recognition of primary care as one of our 5 priorities for Norfolk and Waveney, one of the things that we've done is agreed some additional communications and engagement resource to focus on some of the messaging and the engagement around this, and making sure that you know, we are really sort of in a coordinated way trying to represent what is actually happening on the ground in our practices. Thank you.
Thanks, Sadie. Andrew, you were frozen earlier on the screen.
That's right. I don't know what happened. I had the iPad had indigestion or something. I don't know. I just wanted to, if you don't mind a few minutes, just give you some illustrations of feedback we've got at HealthWatch.
Yep.
And this, I've never been particularly impressed with this survey, I must say, going back years. You might note in their introduction they put the limitations, and they say they're nothing statistically significant. Well, we wouldn't act on the other information that wasn't statistically significant. The design of the form, I don't know if anybody has filled in this or tried to fill it in yourselves, but I had a quick look this morning, and 63 questions long. Now, for real patients, that's why you get such, I suggest, that's why you get such a low uptake rate, because it puts people off. And also, those that do fill in are self-selecting. So those are the people who are good at filling in 63 question-long questionnaires, which is not representative of the population, I'd suggest, and is certainly not representative of the vulnerable population. It's quantitative, not qualitative. So what I want to do really is just put some colour to this question from our reviews we've had anyway at HealthWatch. So this represents April to June, and it's both face-to-face gathering information and people that have landed on the website and put comments or sent emails or something like that. And for primary care, that's 515 reviews. So it's a fair number. Just out of interest for comparison, the number for the major hospitals combined is 67. Now, that's not because there's less problems in hospitals, it's because hospitals don't make it easy. So general practice makes it easy because there's a button to contact HealthWatch on the front page of practice websites, so it makes it much easier. And the limitations are that, of course, again, these are the people that send in comments are self-selected people. The people that are interviewed by our staff out, you know, when they go and visit surgeries are just the people who choose to come and talk. So it's less self-selecting. And of course, there is always when people self-select and choose to contact HealthWatch, there's always a bias towards the negative. It's just the nature of things, unfortunately. So that's, in a sense, not fair. Some I've discounted because they're just, as is the nature of social media, they're just nasty. And you know, are a bit like Facebook and Twitter and things like that, because they're anonymized, so people can put all sorts of unpleasant things. When we approach it, or certainly when I approach it, we try and emphasize positivity, actually, and always make the point to people that if they have a problem, they also need to come up with an answer or a suggestion for an answer to the problem. So I've been on visits to practice and absolutely always engage with people and always suggest that they come up with a way of getting around that problem rather than just having a negative comment. So to distill a few things, there's a real thirst for continuity. So people desperately want to see the same clinician for ongoing problems. Mostly, there's a second group who don't mind about that. Generally, it's younger people with one-off problems who don't mind who they see as long as that person's competent and they're seen quickly. But for people with long-term conditions, people with mental health conditions, people with serious conditions as well, they really value the personal continuity and the personal professional relationship that they can build up over time, and that might be years. There's misunderstanding as well. So some of the negativity comes from misunderstanding of who's responsible for what. So people will make complaint or comment negative comments aimed at primary care about things that are decided somewhere else. So now I don't want to raise the whole subject of ear syringing again. I'm very cautious about that, and I'm sure you're all sick of that one. But it's just an example. There was a comment about, a negative comment about not being able to obtain ear syringing as they had done previously, and that, why should the patient have any, you know, had no clue about the commissioning system and so on that you know all about. That negativity was directed at that individual practice. In other words, the assumption that they had decided they were not going to provide ear syringing, where of course that decision, for good or bad, is much higher up the tree, so to speak. So that might be something he's communicating. There's similarly with hospitals, so the inability of people to access hospitals for information when they've had a test or seen a consultant or whatever to know the test result and or the plan of treatment or whatever, which should be clearly communicated by the hospital clinic they've seen. Doesn't happen. Enormous frustration about not knowing who to contact in the hospital or how to do it. Again, that negativity is aimed at primary care because it's seen as their fault, whereas in fact any problem is secondary care based sometimes. Similarly problems with other parts of the NHS. So when people have problems with district nurses, for example, they misunderstanding is that primary care run district nurses. So there's often the comment about why couldn't they have told, not asked, told the district nurse to go and do X, Y, and Z. That's just an example, but there's no reason why the general public should understand the intricacies of how the health service works. But unfortunately, the part that gets targeted, I suspect, is always the ones that are most accessible and most visible, which is the practices. More specific things, people get enormously frustrated with the phone systems. So the number of people that mention that they don't mind waiting on the phone, because it's the same if you try and phone a bank or any other public service. You wait for a long time because everybody's very busy. And then they get from number 15 in the queue to number 2 in the queue, and the system cuts out. Now that has been reported time and time again. And I personally have no idea why that should be, what the technology of it is, but surely it's a fixable thing. But that seems to be reported again and again and again. And is a simple matter, really. It's nothing clinical, that's just a technical thing. I don't think our public have any understanding at all about the degree of pressure that everybody's working under. They don't understand what primary care does. So they see the individual consultations happening, but they don't see the dozens or hundreds of blood test X-ray results that need processing and thinking about referrals, letters, and all the rest of it. And I thought that was perhaps a slight parallel with my understanding of what teachers do. Now, I do have a bit of understanding because my sister's a teacher, but we all make jokes, don't we, about teachers working from 9 till 3. And of course, that's not true because of marking and keeping up with all the latest information and so on. And there's an awful lot of invisible work goes on, and that's why people are sat in surgeries till 8 o'clock in the evening going through blood test results and so on. But the public, again, understandably, I think, don't get that. So it might be a bit of communication there. There is little or no understanding about new roles. So if you ask a member of the general public what a care navigator is or a social prescriber is, there will be a completely blank look. And that, I include in that people who you might expect to know a bit more about it. So we all know about it because it's our world, but the public doesn't know. And those job titles are a bit managerial sounding, a bit, they're not almost Orwellian, actually, some of them. But they don't appeal to me anyway. And the actual availability, so the ARRS roles, so we hear about having physiotherapists available, pharmacists available, and so on. And I've given this talk to people about how wonderful that is. Actually, when you look at it at a practice, the physio might be available a half day a fortnight or something like that, because that person is employed and spread across the whole PCN, and for the individual patient in the individual practice, really not that much availability. So perhaps need to be a bit more open about that. Communication, similarly, out of hours communication. People are told to go to your nearest minor injury centre. Well, that's Cromer, and that's the only one. Go to your nearest walk-in centre, Ruin Road in Norwich, the only one. If you live in Thetford, that's not too much help. So it's having a bit more, I'd say, honesty, I'm afraid, about the limitations of what is available. And that way we can communicate with the public. Now, Healthwatch, we try and do this. Yes, we talk to people. As I say, I always put a positivity on it, but I'm open. And where there's problems, we do have to say there's problems. Nearly finished. I just want to give you a couple of quotes. Out of those 515, I've picked two. One, and it just shows how opposite people's opinions can be. So one's positive and one's negative. So I'll do the negative one first so I can finish on the positive. So the negative one says, right, I have tried for 2 days to use the online service. It's impossible. Not able to get through on the phone either. Please let us make appointments via walk-in to reception. Stop discriminating against patients that do not have access to the internet or find using the phone difficult, i.e. poor hearing, visually impaired and the elderly. Cost of phone calls spent on the phone waiting to be connected is unacceptable. And then to be positive and directly opposite to that, over the past 2 years, I've had appointments with both doctors and nurses, including telephone and online consultations. Always prompt and satisfying outcomes. The online service obviously saves everyone time and avoids the necessity of travelling to the surgery. I like it. So I won't tell you which surgeries they're from, but there is a difference of view and we will never please everybody. And just one final thought. Have we taken any steps to learn? Why is Hingham so good? So Hingham gets really high positive ratings. Also, I think it's an outstanding CQC practice. And certainly we had a Healthwatch team go there a couple of months ago and they got all highly positive feedback as well. So it'd be really good to know why is Hingham such a wonderful practice? Is it individuals? Is it the patients? Is it the system? I'm sure we could learn from that. Thank you. Thanks,
Andrew, for providing color to that. I'll next invite James and then maybe Kate, I know you have your hand up, maybe can reflect and round up this particular point, but over to you, James.
Yeah, thank you. It's rather too much for me to actually respond to a lot of it. I just wanted to talk about the face-to-face versus online appointments really and the debate on that, which is actually, the government contracted us to deliver 25% of appointments online about 2 or 3 years ago. So there is actually this mutually incompatible drive to delivering online appointments as well as face-to-face. With the face-to-face appointments issue, the ratio is probably quite high at 65% in terms of what people want. Not everybody wants to be dragged into the surgery at a specific time with parking, travel and inconvenience, and it isn't necessarily the gold standard that people want. So if I'm at work, for example, I don't want to have to leave work at 11 o'clock to come in for a 11:45 appointment that may take me 2 or 3 hours for an oral update when I don't need to be examined. Actually, a telephone call, which I can take away from my desk that may last 10 minutes, is the minimum inconvenience. So I really want us to understand that online appointments, telephone appointments and face-to-face appointments are a good mix of service delivery. And there shouldn't be this kind of, we want more face-to-face appointments. There are some people who want face-to-face appointments because they're comfortable with it. But actually, the number of appointments being offered tends to suit that the overall mix from that point of view. So I just wanted to really sort of clarify that actually it isn't one size fits all. It isn't a gold standard. There's plenty of patients who don't want to come near us and actually have to be dragged in because it's really inconvenient. And certainly, if you think of a review appointment post-diagnosis where there isn't any further examination and the physical condition doesn't matter, then a face-to-face appointment isn't required. On that one. The other big myth is that doctors work part-time when they work 3 days a week. Absolutely not. I mean, they do you know, that's 40 hours a week, absolutely overflowing. Most doctors will actually touch clinical work across a 5-day week, even if they're only in for 3 days. And there is a massive piece of work that goes on. If you look at the comment section under all of these GP articles, it must be really upsetting for the practice to do it. And I would say Humble Yard 600 or whatever. I don't know if that was in an hour. That seems quite a lot. But we were certainly taking 1,200 calls a day on busy Mondays. So those actual figures. And if you look at between 5 to 8% of your practice population wanting to contact you in a week, that's a lot of work. But yeah. I just thought I'd add those. Yeah. Thank you.
Thanks. Sorry, Kate, before I go to you, I'll give Bill an opportunity to weigh in, and then we'll round off with you, Kate. Bill?
Thank you, and I apologise for being late. The full council meeting at Norfolk County Council overran this morning, so my apologies for that. I actually bowed out before they'd finished in the end. Just a quick thing here. I mean, looking at the recommendations that the committee is asked to decide on, and that is partly around the drilling down into different practices, and that is one of the key recommendations for the committee to consider. I just wonder if we use the results of this survey as an early warning for practices that haven't been inspected for a long time. So if we have a change in or a movement, then do we as a system use it as a warning sign that for us to investigate further when, you know, it's been several years since a CQC inspection? And is it a symptom of, you know, other problems within a practice, or something that we as a system need to look at? And do we have a way of sort of recording that or using it as a part of a structured management process?
Thanks, Bill. I like the suggestion personally. Kate, lots of input and reflections, not asking you to comment on each and every one, but there may be some takeaway, and then, as Bill said, there are some recommendations in the note that you seek approval from. But over to you, Kate.
Yeah, thank you. Really helpful comments from Andrew and James there, and Bill, your recommendation there about triangulating this information to feed into helping us understand the resilience picture of practices. So I guess for me, there are two bits to this. There's the bit I look to my colleague Shepherd, which is how do we use this intelligence to feed into the picture, the early warning of underlying issues that may be going on in a practice there, where through our connections with the localities and PCNs, we can reach out and offer support in various ways. The other bit for me is the transformation piece, which is the bit that I lead on, which is the strategic development of primary care in our system. And again, using this information to triangulate with other data we have around demand and capacity to help us put this all into a triangle. So we've got a really good grasp on understanding the fragility of our practices and what that might mean for the system. If we have a practice that's going to have an upset in CQC or has other issues going on, what does that mean for the local population? How else is the population served? What could the knock-on effects be for other services in the area? So we've got two strands of work. We've got the contractual resilience bit that Shepherd and Sadie leads on. There's the strategic bit and transformation piece, which is the bit that I kind of look after. And I'm really interested to see how we can use this intelligence in a more meaningful way to support the development of our PCNs. So it's the at-scale working, it's the buddying up system between practices and supporting our practices to work closer together in networks to help us strengthen our resilience. Hingham, yeah, absolutely right. So in the recommendations, there is the line in there about drilling down to practice level, and we're going to be doing that on a PCN and locality basis to learn from other practices. And absolutely looking at Hingham. I don't know the detail of the practice myself, but I'm sure the locality teams do, and we absolutely want to promote sharing best practice across across the piece.
Thanks, Kate. Shepard, did you want to comment specifically on Bill's suggestion?
It'll be a quick comment so that we probably go to the next item, but it was absolutely to agree with Bill, and it goes to the point Hilary made about what is our strategy for primary care in this context. There's a lot of background work that is happening to use data to inform everything that we do. So lots of data sources that we really need to make use of. We are not short of data, and this is really useful information to drive to shape that drive to a proactive stage of managing resiliency in our system. So absolutely, and I'm really looking forward into the future that we'll be able to bring all these pieces of work that are happening in the background so that this committee benefits from that.
Thanks. Kate, final point.
Thank you, Hein. Sorry, the bit that I wanted to say is because the feedback from Andrew and James is about patients' difference between demand and need. But I think as a system, we need to be able to work within our gift, because some of this stuff is nationally mandated, it is policy. And so how can we, within Norfolk and Waveney, work with developing our comms strategy to work it with patients and involve patients through the channels that we have, to spread that understanding of the new roles, the new ways of working in primary care. But again, some of this is within our gift and some of this isn't, because a lot of it is nationally mandated policy.
Yeah, thanks. As highlighted, recommendations are in the note, bottom of page 46 in the pack and top of 47. I'll come to you in a moment, Hilary, but are committee members fine to approve those recommendations? And of course, Bill, your suggestion is being taken on board, I hear. Take it as a yes. Hilary?
Yeah, I was just going to say, I think Kate's right. A lot of this is nationally mandated, and we're kind of stuck with what we've got, and we have to make the best of it. But I do wonder, as somebody sat out in primary care for most of my week, enjoying the experience of patient expectation and lack of capacity, and I would absolutely agree with everything that James has said. Trying to do the best you can to meet need rather than want necessarily all the time. I do just wonder whether we need a bit more of a way of pulling it together locally, that pulls together the data, the workforce, the vacancies, the demand, the survey, the whole thing into kind of one place, because it feels like the acutes are very good at doing this kind of thing, and primary care, because of its nature and the fact that it's disparate, isn't quite so good. And I think actually, if we're ever going to do as the ICB the sort of stuff we talk about all the time, and primary care reaching its full potential and shifting things into the community, etc., etc., I think we're going to actually have to pull it all together and include estates and all those other streams together to actually have a kind of, what do we want primary care to look like in Norfolk and Waveney? And it would encompass everything we've talked about essentially.
Yeah, thank you, Hilary. Good. I'm conscious we took a bit more time, but it felt like the right topic to hear voices around the virtual table. So many thanks for that, and many thanks, Kate, for guiding us through that. I move on to the next item, which is for noting resilience funding. Shepard, you can take the note as read, but can I invite any comments people may have on that note? That's the note starting on page 49, I think, of the pack. Mel?
Yeah, just to highlight, mentioned earlier the comment that Naomi emailed through on the 6th around the additional funding, the underspend.
The underspend, yeah. Shepard, you want to comment on that?
Yes. Just to comment that we have an agreement on how to spend the underspend, which is just about £1,000 left, and that has been agreed by the panel members as well as the LMC colleagues to support a practice that has recently been inspected by CQC. So that is complete now in terms of resilience. All the monies have been distributed.
Thanks, Shepherd. If I may, I'd like to move to item 9, which is the regular updates on the annual health tax for learning disability. We stay with you, Shepherd.
Yeah. Okay. Probably just to start by saying we are really doing very well as a system. So I'm really pleased that we are in a good place. So the report that you have gives you, there's a lot of data there to just show or to reflect on a lot of activity that is going on. So those numbers do represent the hard work from practices, from all the key members within our system. So the first table that you have is a comparative table across our East of England system. And not that we are competitive, but that is really useful to check out how other parts of the system are doing for learning purposes. So as you can see, in terms of the register size, Norfolk is one of the largest register size there. But what I'm really pleased to look at is that we have carried out the most or more annual health checks than any other part of the system, comparing with the other ICSs. And also, what I really like is that if you compare our position in Q1 last year and this year, we've doubled our efforts. And that can only reflect a lot of hard work from our practice colleagues and all other supporting colleagues. So if I take you a little bit to the next quarter, which is Q2. So you would notice in Q2, we haven't received comparative data from NHS England to see how we are performing at that point. But I can confirm that unvalidated data shows that we are now leading across the system. So we have performed at actually 25%, and we are now leading the system. If just to draw out what I can sort of glean from that, clearly you will recall that we did set some targets for ourselves each quarter for each locality and as a system to deliver on. And we are on target of 25%. This is where we said we wanted to be in Q2, and we've managed to get that. But you can see that North Norfolk is a little bit behind on that. We are aware of that. We are having discussions, but we also recognize that North Norfolk has consistently performed throughout the years, and they usually do those in the last quarter. I'd like to spend a bit more time to reflect on the appendixing that we have. So if you can scroll to the bottom of the report, because this was asked by members just to help us to look throughout the year rather than just focus on the quarter. So I suppose the best way to look at this, we'll probably say, let's look at where we are in terms of the total annual health checks that we've done since April 21 to August now. So we've done a total of almost 6,400. And if we look at our total register, it's about 6,900, which means that you could argue from a straight line kind of thinking that 600 people have not been seen. But I suppose we can also say we still have 2 quarters to get to. So hopefully we'll be able to reach out to those people. So that's kind of a straight line, simple kind of look at that. But I wanted to just illustrate the hard work that is going on into this program. So if we take, for example, Great Yarmouth and Waveney, if we look at April, May, if you look at how many annual checks were done in April 21 and May 21 as an example. So it's 34 and 53 in that period. If we go to the right and look for April, May 22, you would notice that we have a 50% increase, or more than 50% increase. And that comes as a result of the changes that we are making in that system. So 50% improvement looking at the same period last year. Let's check probably another locality to just make sure that it's not just maybe isolated to Great Yarmouth and Waveney. Let's just take, for example, West Norfolk. If you look at 21, April 21 and May 21, 10 in April and 24 in May. And if we walk through to March and April, same period, you would look at, actually, they've done 168. For April, they've done 79, and for May, 54. Really a strong improvement and change there. And that shows that there's something different that is happening in this system. And as always, I've said, sometimes I think we are not able to say it all, but I think these numbers shows that there's something different that is happening in this system. And the challenge for us is, how do we maintain this going forward? And those are the conversations that we are having. The next phase for us is to ensure that all those numbers consistently, the quality of annual health checks is improving. I will stop there and take any questions or any suggestions around how we can continue to improve on this problem.
Yeah, I'll invite questions, but I have a couple myself, Shepard. I mean, it's great to see Appendix 1 included in the overview, but my suspicion that I know I voiced to you a few times is that I think there are duplicates in there, so somebody being seen in May 21 and also in May 22. So I think it would be good if your business intelligence colleagues can get it from the data to see how many unique people have been seen, because if we miss out consistently of 10 or 20% of the population that is being targeted, then we're missing a trick. But I'll leave that to you to liaise with your colleagues. The other question I had is on your last point, is to improve the quality. And I read on the last bullet point of your note that you're doing work with the quality team to improve consistency and quality. So can you share some of the things you are working on in that regard?
Yeah, so quality is about everything. So from the quality of data, you would probably have observed that the quality of our data has improved since we started. And the quality of care that we are doing in annual health checks, we've got the peripatetic team that works closely with identified practice to actually work through the coding process and also to work through the standards for doing the annual health checks. And I've been fortunate that I've attended the Learning Disabilities monthly meetings, which clinical colleagues are part of. And it was really beautiful to hear them talking about how to improve the quality for complex cases, looking at how do we actually improve the communications for those that are mute, that are not able to speak for themselves. So a lot of quality stuff going on, but I think the challenge that our team has is how do we pull that together? Because quality is some of it are those things that are taken for granted, but it's about the experience of service users. How do we capture that within the commissioning or contracting arrangements that we have? There is a piece of work that quality colleagues have started in terms of reaching out to practice, negotiating to actually pull together a quality report, which may be helpful once we get to that point for this committee to see. And sorry.
Yeah, thanks. Bill?
Yeah, very quickly, I just wanted to reflect on this is something change is deliverable. This was a decision made in this forum that there'd been no traction on this for a long time, and I know we'd had a number of reports with no improvement. The meeting took the decision that this was something that we felt was important, and it's really heartening to see the change. So sometimes I just feel that the system is so large, you know, but here, you know, there's a consequence of us making a decision in this forum that something, and you know, Shepherd and his team have delivered it. So I just really wanted to say, you know, when something goes well, well done, and it's nice to see it. And I applaud all the ambitions around quality and going forwards, and I support Hein's point about unique appointments, but I just really want to reflect on something that had gone well. So thank you, everybody.
Thanks, Bill. And Shepherd will take it to the wider team. Good. If there is no further question, I move on to item 10, the CQC report. Is it you, Shepherd, or Carl, who will talk to
I'll
it?
take that one.
Yep.
This is another positive news that I'm really pleased to report. Underman Surgery had a CQC inspection back in August, and I'm really pleased that they've maintained an overall rating of good. And just to pull out some of the key feedback around that from CQC is around the face-to-face appointments, that it was working very well. Patients had the option to exercise around face-to-face, and they also had the option to use the digital platforms if they so wish to do. So it's really very positive. And also the second positive thing was around the feedback from service users, which was very strong. So really pleased about the overall. There is an area of improvement that was identified, which was around the safe domain. And the main area for improvement there was around the safe appropriate use of medicines, which on the main was around the variations of around prescription for antibiotics, hypnotics, psychotropic drugs, as well as painkillers, which my colleague Michael has always presented here around the work that is being done to support systems with those variations. And I understand that they are not in a different position from other practice. This is a work that is being done to support practices in general. And I would welcome probably Michael to make a comment on that, if that's okay. Then I think another small area that was identified was around the staff vaccination and management of risk associated with that, which the practice has responded and addressed. Then the final point for improvement was the general inconsistency around the quality of record keeping, which the practice has also responded on that. So on the main, really good to see the overall good rating for the practice, and with the work that as a system we need to continue to reduce the variation around prescribing.
Yeah, thanks, Shepherd. Michael, you want to comment on medicines management specifically for that surgery?
Yes, certainly. I mean, we've been working with the surgery for some time, and it's some of these indicators are in the prescribing quality scheme this year. So we're incentivizing practices to do further work and actively offering to provide some audits in some of these areas. the choice of, I mean, I've had things to say about CQC's choice of indicators and their interpretation of them in the past, but I won't go into that here. They use something called a Z test, which is quite unusual, is what I'll say. Certainly Andaman is a bit of an outlier on opioids, which they haven't mentioned. They are the second highest in GYW on anxiolytics and hypnotics. That's in the PQS and is a long-term piece of work. Certainly everybody's coming down on that, and I'll come to that in my report. In terms of, yeah, so second highest on opioids, as I say, not mentioned by CQC. Their antibiotics, they've picked on a few indicators. I'm just bringing up my data that I've looked at. And for instance, their 3-day course of antibiotics, they're not a significant outlier on that nationally. If this indicator is on open prescribing, they're not a significant outlier. So their Z test, I don't think, has added much to the party there. They say they're not a statistically significant outlier on high-risk antibiotics, but they are, if you look on open prescribing. So again, CQC's interpretation of the data is not that useful, and I think perhaps I should give them some feedback based on this case study. And then they've started using, which I'll obviously discuss with practices at next prescribing, these number of unique patients prescribed multiple psychotropics. Now, this isn't a very easy data set to get hold of. And I have to go onto a portal and have to do an awful lot of manipulation to do what they've done. I have to say, I'll send this to you, Hein, and anybody else who's interested, but as I say, we'll raise it as an agenda item with prescribing leads. And Andaman are quite a long way down the pack on that in Norfolk and Waveney. So there's some surgeries who I shall need to advise that they might want to have a look at this and have a plan for when CQC come in to talk to them about it, because it's an unusual indicator, as I say, not easy to access. So I've accessed it and will be sending it around surgeries, just suggesting they might want to have a look at this and have a plan to assure CQC around it. It's something I probably will suggest we put in our PQS next year, so that there's a structure around doing a bit of work on it. And yeah, the gabapentinoids, they are a bit of an outlier on that one. I definitely accept that. And anxiolytics and hypnotics, as I said, second highest. So yes, definitely. So the data sets and some of their interpretation, I've had something to say about that in the past, but it's certainly interesting, and we'll be working with the practice to help those figures look better. Yeah.
Okay, thanks. Thanks, Shepard, for the update. Michael, we stay with you. Page 63, prescribing report.
Okay, thank you. Thanks, Hein. So my usual report, as I said previously, feedback on anything that you'd like to see, anything specific on, is very much welcomed. Otherwise, I will sort of continue to do cost and quality and pick on a theme. The theme I've picked on this time was ONS, and Anna has written a little section on that. So in terms of cost, the first table, which I haven't labelled table 1, which I will do next time, is the East of England benchmarking in terms of cost per estro PU. And again, we're 5th there, but we are moving closer to average, so we should move another place at some point in the near future. Looking at price concessions, this is a bit of a worry. So table 2 bar chart, you can see price concessions are going up very significantly. So nationally, over the last 12 months, £126 million it's cost, they say, NHS England, and of which 95.5 is in the current financial year, telling you that clearly it's going up exponentially at the moment in terms of a lot of costs. I mean, one of them is aripiprazole, which there's a shortage of, although it's not completely out of stock, and the price concession on that wasn't granted until last week for September. So some pharmacies were reported to have been declining to dispense aripiprazole because they would have made either a £40 or an £80 loss per prescription. So that is a national issue. We have fed up the national through the correct routes, but price concessions do take a while to reassure pharmacies that they will get appropriately reimbursed, which causes some friction in the system. Dependence forming medicines, some good news. So our usual 3 indicators, they've all got better this time, I'm happy to say. Hypnotics and anxiolytics for some time, years. We've been at 3rd nationally, 1st being the worst in the country, but we've moved down to 4th nationally, gone below East Sussex, which is very good news. Gabapentinoids, we've actually moved down to 74th percentile, and that's one that's on our risk register, so we're no longer in the top 25th percentile. So if that continues, I would suggest we consider maybe taking it off the risk register, but we'll just need that to see that consistent movement there, I think. Antibiotic prescribing is still work in progress. There is some work to do there, and you can see on table 6 the various old CCG footprints are differently. There's none of them are achieving both below 10% on broad spectrum and below the new target. The only one that's achieved below 10% and below the old target is GYW, and there's sort of variation around the patch in terms of other performance, and we're continuing to work with our outliers, which I've listed in terms of PCNs and then practices on table 8. So this is all freely available in the public domain on open prescribing. And the Anna in Dietetics has had a look at the prescribing cost spend on terms of ONS, and the ICB is above national, but following the national trend, England trend in terms of cost increases, and lists the various possible reasons why that might be. We have managed to get our enteral fees contracts signed, and so we've got some stability in terms of knowing things about market share, etc. So the team will be working to reduce our costs in that area fairly actively. One significant thing that has happened in the ICB is the approval of the continuing glucose monitoring technologies. So the funding has been agreed, and it is going to take some time to roll that out, and the Diabetes Programme Board are working on an implementation plan which will be communicated out in the near future. They will be doing a health equity audit on it to ensure that uptake of those devices is not based on patients' tendencies to ask, or so that the want is balanced against the need, I think is what we're saying there. And ideally, it should be at the next routine appointment with the specialist. So most type 1 diabetics would be seeing their specialists at least annually, if not more often than that, I would imagine. And we're asking that patients aren't referred just to receive a new technology, because the workload needs to be managed. And clearly any patient who has an urgent medical need because they've been admitted to hospital with a hypo or ketoacidosis will be fast-tracked for consideration and probably will receive the appropriate technology much earlier to prevent those sort of things happening in the near future, provided education and follow-up is in place to give the appropriate technology with support. Questions are welcome. Comments. Thank you.
Thanks, Michael. Any questions or comments for Michael? I don't think so. Many thanks, Michael, for the update this month and attention to oral nutritional supplements. We go to the next item. That's James with the finance report.
Thank you, Hein. So as usual, I'll take the report as read, but just highlight the key points in the report to you. So beginning with the exec summary page, obviously this report is produced in arrears due to the timing of the CCG and now ICB month ends. So it's reporting the second month of the ICB accounts, month 5 of the financial year, and includes a forecast of 9 months for the ICB. You can see from the exec summary that the position of month 5 for primary care and prescribing budgets are £2.4 million favourable to budget for the ICB, which represents quarter 2 to quarter 4 of this financial year. This position includes an efficiency target of just over £7.3 million built into that budget. This forms part of the 4-year efficiency requirement of £8.4 million, and can be seen that these efficiencies are not phased in a linear fashion and do build up over the year. We are forecasting them to be on plan at this stage. Moving on to the financial summary, this shows that GP prescribing is on plan at month 5, with the figures being 2 months in arrears. This is showing the April, May and June estimates cumulatively being accurate. In addition, efficiency savings have materialised in that period, allowing the forecast to be delivered and in some schemes over-delivered. These efficiency expectations were already baked into the budget of the £7.3 million requirement for the 9 months. We've received 3 months of actual achievement, and this has over-delivered. However, this needs to be given with a health check that given the still early point of that, this could change going further into the financial year. There are also some prior year benefits within GP prescribing. There is a prior year benefit and other positive variants within delegated primary care that have crystallised worth 2.4 million, which I'll cover a little bit later. Moving on to the detailed financial analysis, shows the key drivers behind the prescribing spend being on plan. However, there are still some key areas of risk around CGM and SGLT2. There is a high degree of uncertainty over the financial implications of these factors. Moving into specific funding areas, the system development fund STF, this care of investment is showing it's on plan, and it is closely scrutinised both locally and nationally through financial returns to NHS England, but as said is on plan. Moving on to delegated co-commissioning, there's underspend here, which is predominantly due to the way in which PMS, GMS budgets are ring-fenced to delegated primary care, and also some prior credits from 21-22, creating that. Finally, the GP and other prescribing at this slide here shows the detailed variance within prescriber leading to the overall 9-month on-plan forecast. But as Michael talked about before, obviously there's a paper that's been agreed to allow the partial and stage rollout of continuous glucose monitoring for a defined patient cohort of diabetics. This will cause an overall £2 million cost pressure over the next 12 months, which equates to a £1 million cost pressure in this financial year. It's believed the majority of these costs will sit within primary care, as they'll be prescribed via FP10. However, the more complex items may be absorbed by the acutes via their high-cost drugs budgets, but as said before, a high degree of uncertainty around that. That was all the areas I was going to go through.
Thanks, James, and thanks for highlighting uncertainty around continuous glucose monitoring and financial impact. Any questions for James? Okay, thanks very much, James. We come to any other business. First, questions from the public, and I'm conscious we have one member of the public on the call, so I'll check with that person in a moment. But Sarah, have you received anything through email, questions from the public?
No, I haven't.
Thanks. And from the member of the public on the call, any question you may have? No. And then AOB from anybody on the committee? Okay, thank you very much for attending part 1. For those attending part 2, I suggest we take a 10-minute break and rejoin 5 minutes to 3. So I look forward to seeing most of you, and for those who are leaving now, thank you very much and see you on the next meeting. Thank you.